So this is going to be a great session. I've put together some cases that surprised me over the years together, and we have two experienced panelists, Mark Hutchinson, University of Illinois, Chicago, and Margot Putukian. So we have orthopedics from Princeton. We have orthopedics and primary care represented, so I think we can solve everything if we work together, right? Still have no disclosures. Dr. Putukian has some disclosures through soccer and grant funding. Doesn't have anything to do with this talk. And Dr. Hutchinson has some disclosures but doesn't have anything to do with this talk. So here we are, ready to go. Good group. So this is conditions that you may not have seen, but they have seen you. And sometimes I'll let the audience pick the menu, but they've always picked conclusions, so I'm not going to let you do that. So the first case is a football player who basically got crushed. He was tackled. He walked off on his own assistance, so this is during a game. He had pain diffusely about his left side, and I was really worried more about a kidney injury, and I've made some mistakes on sidelines before when players don't want to come out of the game or off the field to try to listen to their lung sounds when people are screaming, and I have trouble listening to lung sounds when there's nobody screaming. So I guess my point is I think you have to take them off the field probably. What do you do with somebody that's got chest pain and got crushed? I mean, can you do a lot on the sideline, or do you try to move them away, or what do you do when they get crushed? Listen, otherwise it's hard to hear. Yeah, so I think you got to move them away so you can get in their eyes and look at them and tell if they really seem like they're hurt, because sometimes they know they're hurt, but they do want to go back in the game. So long story short with this one, we had him urinate in a cup. He did, and it came back looking brown-orange, so I thought he had a kidney issue, and we put him in his parents' car and went over to the hospital, and these are his x-rays. So he ended up having actually 3 rib fractures and no pneumothorax, fortunately. So his acute injury was these rib fractures, but we got a CT scan in the workup for his abnormal urine, and he comes up having polycystic kidney disease. So this is an interesting thing where it probably was never diagnosed unless he broke his ribs, right? And sometimes family history can be a bit elusive. I know you've all seen that in training, in pre-participation physicals, but his dad died of something, the mom didn't know, and he has a couple of brothers, and nobody's been tested for anything. So any comments about underlying diseases in our student athletes?
So I guess is a lot of times these polycystic kidney disease will have hypertension, so the question would be, did he ever, on his pre-part?
He didn't. And he was like a sophomore, so he'd been around for a little bit.
Yeah. I mean, I'm not sure what the incidence of polycystic kidney disease is in the general population. That's better. But certainly it would be something that if you found this diagnosis, it would probably make you consider not allowing him back into participation in football.
At any level? Like he's going to play professional football? Or?
Yeah. I mean, that would be me. I don't. What about folks in the audience? There's probably a lot more experts out there than up here.
I would wonder about the issue of the incidental finding, because this was, now you have a rib fracture. You didn't know this. He's been playing forever. You didn't really know there was a problem with his urine. It just happened because it got hit this time. So it's an incidental finding. So does an incidental finding of polycystic kidney disease change from actually some symptoms that led you to make the diagnosis regarding return to play?
I mean, to me, I think this is very different than if you incidentally pick up that you only have one single kidney. That would be a very different discussion. I think with polycystic, the concerns are related to the increase in bleeding and the issues related to that you can have with this.
So what I learned about this is that there are other organs that can have cysts throughout it, and this was somebody that was competing at a level that he wasn't going to be professional. There wasn't a big discussion about it, and we disqualified him. So fluid-filled cysts in a lot of different solid organs, kidney, liver, pancreas, And as was stated, 50% of them have hypertension. So this is something this isn't a session to get paranoid about everything, but if you have a kid with hypertension and you have an abnormal UA, you might think about polycystic kidney disease. But they get cysts in a lot of different places, including cerebral aneurysms, aortic aneurysms. And when I start reading this list, I don't want to be on the sideline covering this kid. And he was pretty good with it. We did get his brothers tested as well. So I think that's something to be aware of, underlying conditions that may be totally asymptomatic, but you want to do the right thing for the athlete. And also I've been in some situations where I've been asked to cover cardiac patients, and if I don't feel comfortable doing it, I think you just have to kind of put your foot down. I don't have a cardiac case, but what if they give you a defibrillator for a cardiac issue and say, follow this kid around? What do you do? I don't do it, but
yeah, well, it's interesting though. In one of the cardiac cases, that's exactly one of the presentations was someone, I'm trying to remember what the underlying issue was, had catecholaminergic VT, and initially was diagnosed at a very young age and was not treated with an implantable defibrillator. Subsequently had at an age of, I believe, 17 or 18, had a syncopal episode and a cardiac arrest, was resuscitated, and then matriculated to college. And they cleared him to participate. I personally would not have, but that was the discussion. I'm sure several other people here were in that case discussion that Aaron Baggish and Paul Thompson led. So those situations come up quite a bit, and you have to sort of take them case by case and figure out what the concerns are. And I think now we're in a shared decision-making, with the family, depending on the etiology of the condition.
Right.
And, but I, like you, would not feel comfortable if you have a known issue that causes sudden cardiac death, just to sort of say, okay, we're going to have an AED and we're fine, right?
And I think it's about communication, with the whole team too, including your athletic or your administrators, and because there's obviously a liability issue. But I just don't want to be there on the sideline when I can't resuscitate.
You're right.
Somebody
And in fact, in this case, what was even probably a little bit more disturbing was that the cardiologist that had evaluated him had told the athlete that, I think he was a competitive diver, not to reveal his problem in terms of being recruited for college scholarship. So that was actually very concerning.
So good comments. This is an 18-year-old who finished his fall season of football, including contact, and over the break, after his fall semester, he was weightlifting, bench pressing, and he noticed that he had electric shocks going down both of his legs. He was about 2 hours away, and so the athletic training staff said, come see me. So he arrives in my office with a progressive lower extremity neurologic situation where he had clonus. It was bilateral, more on one side. And these are his plain X-rays, and this is again another underlying condition that don't get paranoid, because I am, but he ended up having a vertebral body tumor, and that may not project too well, but if you look at that, it looks a little honeycomb. It doesn't seem that there's any collapse or anything like that, but he had electric shocks going down both of his legs. And the thoracic spine's a little hard to image, so we got plain images in the office, and there was a little bit of a compression anteriorly to it. And then this is the MRI scan. Any comments about that from the?
Actually, I think probably the biggest clue for me was on the original X-rays. You couldn't see the pedicles. So on the AP views, you saw pedicles, and at that level there wasn't any. So that was your clue that there was some bone erosions, even at the. So my X-ray, that's what I had some pain, I had some issues, and I saw that, then I'd be probably scared. And then you proved it out with the MRI.
Right. So he has a abnormal vertebral body here. And if you look, it does look like there's some compression of the cord. Discs look okay. And this is his axial view. And so you can see here where this vertebral body looks abnormal. And long story short, he had a CT scan. He has a hemangioma that is a bony abnormality that's a birth kind of thing. This is why he developed his lower extremity symptoms. And what we postulated was maybe he was valsalving and he had a lot more pressure from lifting weights. He'd been out playing football. I mean, so, you again, don't do a T-spine x-ray on every football athlete, but if they have some back pain, then that might work. That might warrant workup.
Question for you: with him, how did he present? Was it over? It was
no, it was acute.
It was acute.
He
so
was weightlifting
at
home at Christmas time. Calls the trainers. They say get down here immediately. And so I saw him, and he was having this progressive neurologic event at that time. So hyperreflexic, and it was one of those things where where do we go now? So he did have a neurosurgical consult, and they did an embolization on him because this is a bleeding tumor. Unfortunately, he developed a DVT, so they had to take care of that. And anyway, he ended up with a Brown-Séquard syndrome that was permanent, ambulatory with a cane, no competitive sports. He ended up being involved with the team. And this was one of those where it scared me a little bit because he was out there being hit, but he ended up having the problem. So this is what the hemangioma looks like in the upper left here. These are other vertebral body abnormalities. So it's a little unusual in this age group, but hemangiomas do happen.
Did he develop the Brown-Séquard after the surgery?
After, yeah.
So it was a surgical complication.
Probably, yeah.
And I think it's intriguing. I think we all kind of look at this and go, okay, I have an acute progressive neurologic loss. You go, okay. That one I should know. I should be aware of because I'm dropping. Everybody should know that. My challenge is what do we do with this same athlete? He probably had this underlying, and starts developing pain. I got some pain back there. I got a little numbness occasionally. It's a little bit more chronic presentation. How fast should we then turn around and say, I need imaging. I need to go look for something, rather than just say, oh, he's an athlete. He's got a little back pain. I'm going to go do therapy and athletic training. I'm going to take some medicine for a while. How long do you wait before you progress?
Yeah, that's a good question. I mean, I probably, if somebody was having a leg pain, I'd probably think of his lumbar spine and not necessarily his T-spine. So you could do a workup and not go up high enough. And I do think it's interesting where I think the vertebral body cortex finally kind of blew out, and he had a bleed that affected his cord, is what we thought, because he was just bench pressing is what he was doing.
I mean, you're probably right. I think if I had seen this, I would have thought, okay, you have like radicular symptoms down both legs. I'd get a lumbar spine.
Right.
I probably would miss.
I probably would have
missed
missed
T3,
it.
right?
Yeah.
Great.
So anyway, he didn't have the best results, but it was handled well because we saw him, and that's something where you have to see the patient. You can't, and your trainers are your eyes and your ears, so if they say see somebody, you got to see them quickly. So this is a softball player, and this was a situation where the athletic training staff could, under my supervision, order x-rays, and they'd go over to the hospital. So for a while she was one of those complainers. I don't know how many complaints she had, but they were recurrent, different areas all the time. So it's like, she's complaining again. So I thought she might have something like a pleuritis or a little chondritis of her chest, because she was having right side chest pain. I saw her in the training room, and she ended up continuing to have problems. And so I said, okay, let's just get an x-ray. And so the trainer, I don't know if anybody knows Bobby Barton, but he goes, Doc, what you going to do with this tumor in this rib? I said, what? So he got the report before I even saw her again. And anyway, we had gotten, again, lumbar spine films on her in the past because she was having recent back pain, and it was about the time she was having rib pain as well. And anyway, bowel gas can be your enemy because sometimes the bowel gas will obscure things. But if you look here, there is an expansile lesion of a rib, and that's not costochondritis, as Dr. Barton said. It's like, what you going to do with this tumor in her rib? I said, well, I guess I ought to see her first and go from there. But any comments about that? Sometimes bowel gas gets in the way, and then...
I find it interesting.
So there's another bowel gas. So see, that's when bowel gas got in our way. And then this is when she was having persistent symptoms. And but that was probably her start of her ABC up here, but we thought that was bowel gas.
What's the time difference? 3
3 months. Yeah.
How many physicians in the audience have kind of a standard thing with their athletic trainer or team? You had a standing order that goes, I'm in my office, I'm seeing patients, go ahead and go do the x-ray. How many people do that? Because, this is something that occurred here. And how many people say, no, they're not going to automatically do that. Every one of them is going to get seen first.
Well,
actually, I would say first. I'm saying you're going to, before you do any imaging, you see the patient, or the second choice is to say, get the x-ray, I'll see it. Because for me, the differential diagnosis, I've got this chest pain issue, but I'm just scared of chest pain. And so, I probably sit there and
That's
go...
why you've got Dr. Putukian.
Yeah. Are they breathing okay? Right. I'm going to screen this other things before I am calm enough to say get an x-ray. But there's really going to be some communication probably that occurs for my concern.
Well, so there are times when, an athletic trainer will call me and say, this kid just, sprained his ankle or hurt his finger, you're going to probably want an x-ray, where I'll order the x-ray and then see them after that. Was that your question?
Yeah, just the kind of this timing of what we do. We had a couple people in the audience that said, no, I've got standing orders, and actually, I'll admit, my training room, my guys sprain an ankle or something like that, and it's not dislocated, they have standing orders to get basic ankle x-rays that I'm going to see, and it just goes. Chest stuff, I think I want communication. They might get the imaging first, but the chest stuff is going to say, are they breathing okay?
I think you have the protocol of, depending on the situation of chest pain, obviously that's a little bit different, right? So I'm going to want to see my athlete with chest pain, or I'm going to want my athletic trainer to send that athlete to the hospital if that's the way that they need to go, right? So they need to be able to triage them and figure out, is this something that's cardiac? Is this something that's a PE? Is this something more significant? Or is this something that they can be seen? It probably need to be seen pretty quickly.
And it's all about communication and probably having written protocols in this day and time, but with x-rays that you can be beamed to, then I think you also have to make sure you see the patient.
Yeah.
Sometimes you can maybe have an x-ray you look at and then you don't see the patient. So
we at Princeton we have an infirmary, a 24-hour infirmary, and so we have physicians on call, but there's a lot of stuff that happens that our nursing staff does, and it's per standing orders, and I hate it, because then in the morning when you're sort of going through your notes and you're sort of reading what happened, and you have to have there is that level of communication that, they a lot of times will just send someone to the hospital, but I think it is a little bit of a challenge. And you're right.
And this facility was a little ways away, and so I actually, said the x-ray was okay to do, and I'd seen her before, so it wasn't as much of an emergent thing of like, okay, now it's time to get another x-ray. Because we got back x-rays. So these x-rays were actually when she was having more back pain. It wasn't rib pain, but that's probably, I think that's her ABC, or is that bowel gas? It's 3 months, so that probably is the start of her ABC, and then she started having increasing, it wasn't acute, but it was just increasing pain. And so here's her bone scan. Nobody gets bone scans anymore. Has anybody ordered a bone scan in the last 5 years? Cool. It's kind of a forced entry thing. I think it's a good test, but I'm told that it's getting more expensive, and maybe bang for your buck might be another study like an MR. And here's her chest x-ray. So we did do a biopsy before doing an excision, and this is what her excised rib looked like, and I did this with a cardiothoracic surgeon. She did well. I was a little concerned about that rib maybe spear chucking a lung, because you can't really smooth the rib off completely, but she ended up, it took her about 6 weeks to recover, and the pain went away in her back and in her chest. That's what the path looks like. So this is a aneurysmal bone cyst. The typical time frame of this is 6 to 25. It's expansile, so you can have a pathologic fracture, excellent prognosis, and usually you excise it, or you can inject it with certain things, and I think still they're using some type of steroid or something like that. I don't think we're injecting liquid bone, but that would be something that you would think you could do. It's not a primary tumor. Sometimes it's thought to be a secondary trauma infection or pre-existing tumor. So that's her ribless right side. Pain went away.
So, Mary Lloyd, is that now still the treatment? Is there a way to figure out the diagnosis without having to do a resection?
I think she was symptomatic. Maybe she probably had like fracture. I mean, so it was so expansile. I think her pain was probably because it was an expansile lesion, like a rib fracture, probably. That bone, since it's rib and a lot cartilaginous, I think the excision would still be the way to go. Now, in another bone, probably not, like proximal tibia or something like that, probably not. So interesting case. So we'll move on to shoulders. And again, don't get paranoid. It's not going to be the patient that you see. But if you think about some of these cases, you might think a little further because you may see it. So 31-year-old, she's continued to have shoulder pain. She wants comes in wanting her shoulder scoped because she's had shoulder pain for a couple of years. So my rule is that I want to get plain films within a year of when they have had the last one if I'm going to operate on them. And I think a lot of times we jump to MRI scans and we don't get plain films. In the tumor world, Dr. Enneking at Florida, would always do plain films, and I think that's something that I see a lot of patients coming in, maybe for knees, that haven't ever had plain film or standing films, and they're 60, and I really strongly feel that they should have good films. Sometime if they're younger, I won't necessarily repeat the films, but I think in somebody that's got knee pain, you probably need standing films, particularly if they're whatever middle age is, if they're a little older. But so this individual, I did get another x-ray. She'd had an x-ray done 18 months prior that was normal, and if you look at her coracoid, it looks a little funny, huh? See how it looks a little expanded there? Mm-hmm. And she had anterior pain, kind of was subacromial, didn't have a lot of weakness, but she was just having pain. So long story short, that's an abnormal coracoid, which is really weird. And this is what the coracoid looked like. So if you look how expansile that base of the coracoid is, it's not normal, right? So this isn't normal bone. It's more lights up like being a cartilaginous. And long story short, she had, I sent her, we didn't have a tumor person at that time, and she had a low-grade chondrosarcoma. So she had I think they call it a half, whatever that means. Not one, but a grade half chondrosarcoma.
Who are you?
I don't know.
Supposedly in practice, in your entire career, you're supposed to see one tumor.
Well,
and so
I'm either real old or I need to stop seeing who I'm seeing. I don't know. I mean, they're just, yeah. So I didn't scope her shoulder. That was a good thing.
Or maybe it's this message that if you haven't looked for it, you haven't seen it. So
right.
You're looking more carefully than the rest of us because they talk about one per career, but you've certainly seen your fair share. One of the other lessons I have from this one is your patient population. So, if you guys saw that it says it's a lawyer, now you sit back and go, does that affect your decision tree? I will tell you, I'm always much more sensitive with lawyers, doctors' families, and so maybe I shouldn't be. I'm not trying to be change my practice with them, but they tend to get weird things, so I pay more attention to them.
I would also say, I think this is, we're in the day and age where the comment you made about plain films is really illustrative to me. The couple of tumors, I've had a couple. That I've seen, where one was literally a kid with a muscle strain. And I think in this day and age, many of us are, using other tools and not doing things like just getting a plain film. And he had been seen and followed by an orthopedist elsewhere, and then he came back to Penn State and ended up, we just got an X-ray, ended up having a Ewing's. So that point, I think getting plain films and not forgetting to sort of include that as part of your initial evaluation.
And I think it's hard because you can read reports, but you really need to look at the films. So that was a little scary because, easily you could have just said, okay, you want a surgery, you're a lawyer? Well, let me think again. And I will flat out ask lawyers what they do, what type of law they practice. And, because if they're going to sue me before I operate on them, I'm not going to operate on them. My brother-in-law was a lawyer, and he got really upset with me one time because I operated one of the bad lawyers. So they're good lawyers and bad lawyers, but I said, you tell me anytime you're operating on a lawyer, and I'll tell you if you should. So you don't have to operate on them. It's an elective thing. You have to take care of of them and diagnose them, but I do think you need to have your radar up a little bit if there's certain, or even patients that make you nervous. They're trying to drive what you're supposed to be doing. I mean, that's something where you have to be comfortable taking care of the patient, and if you're not comfortable, then they're not comfortable. So I do think you have to still, stick to your guns, so to speak. And I hate to say these are all my cases, so wow. So this is a 16-year-old linebacker, baseball athlete. It's his non-dominant side. He's got basically left shoulder pain that started like 4 months ago. He'd been doing some heavy lifting. And again, I start with the plain films. You guys see anything on the plain film? These are not the best of films, but retrospectoscope is always 20/20. And it's interesting with the new digital x-rays. These are the old x-rays. But sometimes the density's a little funny, or I don't know, do you see that? And you can adjust it, but sometimes they're just a little different than the old-fashioned x-rays.
You're absolutely right. We actually just about 3 years ago put in new monitors and the digital monitors, and it scared the crap out of me because it was strikingly different, the resolution and what we were seeing on our laptops, basically, compared to what they're on the great monitor that they had. Mm-hmm. It was all based on the resolution, stuff above my head. But. And
it seems like they're darker, and so you can't see as well. I don't know if you're seeing that, but if you're concerned or you say you can't see something on your monitor and that the radiologist has read it differently, then maybe you do need to figure out if the sequence is right or if the monitor needs something different or some other way for you to see it.
Yeah, but I think with the modern imaging, then it gives you the advantage of playing with your own contrast,
right.
So that you can change that density. It shows things different up. When you have the standard X-ray, you were kind of stuck with it. You could hot light it a little bit, but it allows you to play with it from that perspective. How many people in the audience actually, honestly, review their own X-rays?
Yay.
Okay, good, because I mean I've seen so many times where people they depend on a reading by somebody else, and if you don't check, you're not going to get good at reading these, and then you're going to start missing things because you're dependent on the radiologist, who then you have to trust which one did it.
And it's hard to get them on the phone sometimes, but if you do have a concern, we call them. I mean, and I think you really do have to do that. I've written love letters to the worst radiologist in the country about how terrible he is, and not he is, his readings are, and he doesn't say what he sees. He tells me what to do. So he never responds to my love letters. So I guess I need to call him or go down and actually talk to him. But those readings can get you in trouble. And the other thing that I like to do in the office is I'll print out one, go and show the patient, because their family already has seen it or the patient's seen it, and they're thinking they're having a big problem. And so you explain, or whether it's an MR, talk them down off the cliff, because they need to look at that and see what you're seeing, because they'll go to another doctor and say, well, that doctor said this and missed this and yada, yada. So the patient doesn't get better, and you may end up getting sued. So left shoulder pain, this is a 16-year-old. He's got a slap, right? I'm going to scope him. I'm not a big MR everything, but fortunately I did get an MR on him. Any Dr. Hutchinson, you see anything on that?
Well, again, I'm still worried about your tuberosity, that you had some sclerosis. He's got some
like
fluid.
Maybe here.
Yeah, and he's got some. There's actually I look at that now. I mean, there's the sclerosis and stuff that you have there, but it also closes down your bicipital groove, so you start wondering if that would irritate the biceps.
So you basically have a space-occupying lesion mass in the bicipital groove. And what I'm thinking is, hey, he's got a slap, I'll just scope him and he's going to get better. So his labrum looks pretty good. So usually in differential diagnosis in this age group, it's slap, partial cuff tear. They usually don't have subscap problems. And I've been looking for one of these tumors for like 25 years. So this is one I was happy I finally found. But so normal labrum, and he has this lesion just lateral to his biceps. And I ended up excising this lesion, and it was a chondroblastoma or a Codman's tumor. But this is a healthy kid linebacker, so this is something where if you don't have an exact mechanism, a lot of these kids are getting beaten up, lifting or hitting, but he non-dominant shoulder, and it just started hurting. It had been hurting him for 3 months. So so I did a case without a scope. That's reportable. But
I mean, I think one of the questions that this brought up when I was reviewing some of these is whether you're using ultrasound or whether you're using an MR, right? So, like, this is a clear indication. You wouldn't have picked this up, I don't think. I mean, there are folks in the audience that are better at ultrasound than me, but I don't think you'd have picked this up, right? So that's one of the things that's a discussion that my orthopedist that I work with, we go back and forth in terms of, the benefit of using ultrasound, things that we can pick up, and then this points out sort of, well, guess what? There are a lot of things. There are some things that you're not going to see. Right?
So get a plain film, and the history again was pretty consistent. He could have had a slap, but and that bone lesion again, I highlighted this plain film, but it was there on the plain film. In retrospectoscope, you can see these, but I still probably wouldn't have seen it going back. And then, so basically, an excision was done, and this is the excised and basically proximal humeral lesion. Chondroblastoma is very rare, but it's a Codman's tumor and is a classic description of this. Osteoid Osteoma is another one, atypical enchondroma, infection with sequestrum. And I have seen actually one osteochondritis dissecans of the glenoid that we worked up, so not really a tumor, but that could be shoulder pain. But basically, he had biceps pain because he had a lesion, chondroblastoma, pushing on his biceps. So you can have other things in the proximal biceps glenoid complex that are unusual.
In the more mature population, I would potentially consider clear cell chondrosarcoma, but it'd be older. Now, which introduces a different challenge. And that is that, I mean, I'm an orthopod, so I'm going to say most of us are not orthopods. Should we expect our primary care doctors to send this to us, or should they pre-screen it and go, oh, I got an MRI scan, I got a tumor, they need to go to a tumor doctor?
Yeah, that's a good question. So this is a benign tumor that we didn't have a tumor doc in town. Probably now I would send it to a tumor doc. But I also think if it's something unusual, just send them a good consult with your ortho team physician is probably better than doing a lot of imaging because, he could have had a lot of other studies or gone through a lot of stress about what is this, and we pretty much quickly made the diagnosis and took care of him. So I think it's a lot about communication, and I think that we can, the sports people can take care of him if you're comfortable about the shoulder, which I was, but if it's a benign lesion, then we can probably take care of it. But I would bounce it off of my tumor colleague, and we don't go, as orthopedists, we don't go biopsying things that we're not going to treat formally with an excision and take care of them. So I think there are more tumor people out there now, so I probably would have had him seen.
Yeah, I have a tumor doctor who actually shares clinic with me in one of my clinics. So you talked about the communication. It all gets back to communication. I probably would have showed him the films. He goes, that looks benign. Then I would have done exactly what you did.
Right.
But I probably would have had it double checked to go, really? Is that sclerosis thickening? Is that really safe? And because you got to be careful surgically. You want to be careful not to take a path that's actually going to make it worse for the patient if they actually had something malignant.
Right. So when we look at epiphyseal location, his plates were closed, but you also have to think about certain things in skeletally immature, pigmented villonodular synovitis, giant cell tumor, chondroblastoma, ABC, or tuberculosis. So those are just some other things to think about. So a 12-year-old soccer athlete comes in with left shoulder pain, maybe a couple of years, no injury. He basically had normal stability. The fellow that worked with me at the time said, this kid's fine, there's no problem. So I went and examined him, and I did find a axillary mass. He's in there with his mom. He doesn't want to be there, seeing me.
I'm scared. Everybody's scared? If I palpate a mass...
I'm not going to go see Dr. Ireland.
Peter Gervino said he's scared for my patients. So anyway, long story short, he does have an axillary mass. And it's funny, when patients come see you and you suggest a study, sometimes they don't want the study. And this mom said, we don't need to do an MRI scan. It's like, well, you're here. You've got this mass, and I'm concerned. I want to get an MRI scan. But fortunately, his aunt, the patient's aunt, sister-in-law of the mom, was a pediatric rheumatologist and helped me out to get the study. So it's unusual because usually people come in waving an MRI scan they didn't need to have, and in this case I had to talk them into getting an MRI scan. So anyway, what do you think here?
Could you visualize the mass, or was it just when you palpated it?
I palpated. It was a significant mass in his axilla.
No, I get it, but I mean, how many of us, when you do your exam for a shoulder exam, kid 12, I don't care what their age is, did you actually reach into their armpit? Does anybody? I mean,
it wasn't Harry yet. He was only 12.
I'm saying, I do my range of motion. I'll palpate the cuff. I check impingement. I look for slaps. I do all that stuff. But I don't think I routinely do that. And I think it means, be willing to put your hands on the patient.
I mean, the skin was normal. It moved a little bit. Wasn't real firm. But when you did have him, say you're being arrested, maybe and got him back like this, you could tell there was an asymmetry. But you're right. You don't really palpate their axilla. I mean,
so it might be like take-home messages. Make sure you examine the athlete with their shirt off.
Right.
I mean, a lot of times, how many times they have a T-shirt on, you might not necessarily say, hey, can you just take your shirt off so I can just take a look at you.
Right, and I think that's
with our
really,
female athletes
really
having
key.
them with a sports bra or something like that. I think that to me was the take home there.
Right, and then you can also look at their scapula and things like that. But so this was the lesion, and he had a synovial sarcoma and he underwent resection and chemotherapy. He went on he didn't keep on playing soccer, but he was a Boy Scout, and I saw him 4 years later for anterior knee pain, and he looked at me like, do I have another cancer? But they did come back, so they were brave to come back. So if you had anterior knee pain, it was fine. So this is an interesting adolescence or invincible kind of person. So basically, she had broken her wrist, and she went out and, did something on a log, and then she fell on her other side. So she already was in a cast for this wrist fracture, and she fell, I think she was trying to cross a stream or something, and maybe the cast made her off balance. So she fell on her other side. Anybody see anything on this x-ray? So again, seems like with humerus, I didn't tell you the first time, but with humerus x-rays, it seems like they're kind of bad when people have a fracture, just maybe because you can't position the arm right, but it just seems like a lot of the x-rays aren't that great. So, it'd be nice if it was a little more penetrated. But long story short, with her, she had a bone cyst, a simple bone cyst. So if you have somebody with minimal trauma having arm pain, like they throw a ball from the outfield and all of a sudden they develop mid-shaft humerus pain, think about an underlying reason for it, and it's a benign reason, but it's a unicameral bone cyst. And we actually have seen probably 4 or 5 of these, and Ed McFarland at Hopkins had a few. We were going to write them up, but we never quite did that. So basically, now look. So we just have her, and then just not using her arm. Didn't really put her in a cast, just a sling. So his epiphyseal plates are still open, epiphyseal plates are still open. So at 6 weeks. That's what she looks like. So you can really see, as opposed to here, you can kind of maybe see a little something, like right there, but it doesn't really project very well.
So was it evident in the beginning that it was a cyst?
I couldn't really tell, but I'd seen a couple of these before, so I couldn't really tell that well. And do you image them or do something else? Probably not. But that's another treatment for some of these cysts. Is if you break it, then they usually fill in with better stuff. So she's wanting to play soccer at 5 months. I said, well, okay, but then she comes back for another problem, and I said, can I X-ray your humerus? And it's like, oh my gosh. So she's out playing soccer. She's doing okay, but I was a little concerned about the thinness of that cortex. It filled in on the lateral cortex with the medial cortex.
So are those ones that you would put bone graft in there, or
she's not symptomatic? So she's not having any pain at all. So didn't do anything.
Sometimes
might be a little difference of her tibia.
Yeah, you see these in the heel, right? So sometimes you pick them up incidentally when you're getting an ankle X-ray, and you see a big calcaneal cyst that you sort of have that same reaction, like, is this going to break through? Right, and I don't think we have any great goo, so to speak. But now this is her 3 years later, so she filled in. She filled in completely with that. And this is this 15-year-old baseball outfielder, throws the ball. His arm follows the ball to the plate, almost. So this is. You can see his a little bit better, though. See how you can see there's kind of a hole in the bone. And again, it's not like that aneurysmal bone cyst. It's more of a unicameral bone cyst. So it's not the biggie. So. What's the diagnosis with this? Constipation?
So we talked about taking clothes off when you're examining patients. When you send them to x-ray, it's pretty amazing what the x-ray techs do. So this was a hydroculator pack that was on the back that we were getting an x-ray of her pelvis and didn't. So that's an external tumor. So that one was that one's pretty easily. Well, it could be, but this was a long time ago. So yes. Any questions on the hydroculator pack?
As you do that, the other thing that's I think with the modern day electronic imaging that you saw those humerus fractures, I will tell you didn't get to see it on the thing. I got to see it on the computer before. If you played with the contrast on the very first one, you go, oh, there's a fracture. You actually could see a radiolucent lesion that probably pre-existed the fracture, like you saw on the second lesion. So I think with the modern techniques, when you play with contrast, it can actually improve significantly your prediction of what's going on. And in some of these, what have you been learning here so far? I mean, in terms of, Mary Lloyd's been presenting some of these atypical presentations, but what are some of the key learning points that I know that I've been jotting down to say what we're going to talk about? Expand your differential, absolutely. I think it's one of the most common things that we end up shooting ourselves in the foot, especially with the athletes, because you're just looking for that common injury, and that if you're not willing to consider that broad differential diagnosis, that you're going to miss it. So I think that's one key lesson that I picked up even so far. What's any other one? Because I picked up two just even sitting on the panel. One is very broad differential diagnosis. The other thing I've learned from Mary Lloyd, I was her fellow, so I got to watch her act. And I can remember one time on the sideline, some guy hurt his foot, and she kind of goes in and just says, "Okay, well, where do you hurt? Back of your heel? Okay, I figure it's Achilles tendonitis, maybe a calcaneal fracture. I don't know." She reaches in, grabs the guy deep. Oh, well, you got a stress fracture of your accessory ossicle of your navicular. I go, what? And that all became because of exam. Because, once you have that broad differential diagnosis, you reach your arm into the axilla and you do a complete exam. And that's going to help you with some of these too.
And sometimes you just look at these kids and they're kind of scared, like that hemangioma of the T-spine. I mean, he was scared. I was kind of scared too, but I didn't let him know that. But, so I think you really look at them. Sometimes kids don't want to look at you, so I think you kind of have to push the parent out of the way and try to talk to them. And sometimes they are scared because of some of these things they can't control and don't know what's happening to them. So we'll talk about heel pain. This is a basketball athlete who was having heel pain. He got better if he took naproxen, but he had developed a GI bleed. He was seen by a pediatric rheumatologist who told him and his mother they were both crazy, and they were having some type of a relationship because he was crying at night and she was in his room. So they come to see me, and he has heel pain. So it's right on his heel. It's not on his navicular, not on his Achilles. And in an adolescent, you have to think about certain things. It's differential diagnosis, Sever's disease, something rheumatologic. I had a family member who had this weird MRI scan, and we thought he had a midfoot fracture, baseball athlete. And long story short, he ended up having Reiter syndrome, but I missed it until he had eyeball problems. So beware your family members. Not that you have to work them up a lot, but you do have to treat them as patients because you end up saying, suck it up. But sometimes they can't because they really have a problem. So tumor infection was my differential. And this young man, and you again, retrospectoscope, it's a little hard to see, but this is a abnormal. So plate's still open. That would be where you'd have some symptoms from Sever's disease, but the x-rays look normal. So see right there? So he has an osteoid osteoma. This is a CT scan. And we end up excising it. It's a little hard to find it, so at that point we put in some markers so that we could find where it was, and we did. This is the last and only time I'll use a Cloward neck drill, so we took a plug out, and that was indeed what he had was an osteoid osteoma. And I think we influence a lot of these young athletes. A lot of them go into sports or go into medicine, and he is now a musculoskeletal radiologist in town, so that's kind of cool. So if you're worried about a patient or athlete and you can't sleep, then you got to get them back in. And this was fortunately one that I didn't operate on. Somebody else did, but you can see sometimes we see bad things, regional pain syndrome, pain out of proportion. This does happen, not that usual, but in an athlete. This was actually a motor vehicle accident. So consider a condition that is not what it seems. If The pain is unusual. It's persistent. Night pain is a big thing, I think, and if you have a bad feeling. This is this successories knot, so it could be that the purpose of your life is to only serve as warning to others.
Yeah. Who are you? Yeah.
Yeah.
I'm not the Grim Reaper. I mean, my mother gave me a coat that did look like the Grim Reaper. It was great because it was really light. It was black down to my shoes, and it had a hood on it. I said, "Mother, I can't wear that on the sideline. They think I'm coming to take them away or something." Warm though, I still have it. So I do have a website. Go to that for some of these presentations, and hopefully we'll have some of these. Any questions? Come up and find us. Any comments? Any parting comments? We got a couple of minutes.
Though I think I would just reiterate what Mark just said, which is a lot of times I'll never, forget some of the patients that I've seen. And again, you have that I'm a sports physician hat on, so I can take care of musculoskeletal issues. And the one that I think we presented here a couple of years back was a young volleyball player came with her mother for knee pain, and she had been sitting on a step and then turned to go upstairs and had knee pain. And she came in, she had an effusion, and she had some joint line pain. So I'm thinking she might have a meniscus tear, and I'm really not thinking like an internist, right? I'm thinking like I'm the sports medicine doctor. And so I said, well, we should, let's see how you do, and gave him a little bit of a treatment plan, and if you're not improving, we'll consider getting additional testing. Next morning at 7 a.m., I get a phone call. She's in the ER, again, with her mother, and they want the MRI scan. And I'm ticked off because I'm thinking they're just there because they want the MRI scan. Long story short, she ended up having Gaucher's. She had splenomegaly, pancytopenia, and it was completely a medical diagnosis that I had missed. So I think part of it is, like you said, you never know that things are seeing you, and sometimes you have to be, able to broaden your differential. That's what I've learned from.
And you do have to be humble, because you never see it coming. I mean, look at these two water bucks; they never see it coming. So I mean, I think we do have to be humble because don't get pissed off because they're in there getting an MRI scan because they probably needed it, and you kind of have to back away and. You kind of get a little huffy, but then you treat the patient, do the right thing for the patient. Sometimes that's hard to do.
You notice this picture, Mary Lloyd's got the nice the lion, the cheetah, and Margot and I are the two bucks.
Or the McDonald's. Those are McDonald's.
I think we're still going to get hit if we don't pay attention and look for all these crazy differential diagnoses and do complete exams.
Yeah, so I would encourage everybody to go Africa. It's a circle of life thing, and the Impala or the McDonald's sign, they've got a McDonald's sign. So this is a toilet seat sign. They sat down on a wet toilet. But I guess in nature they do that so the babies know who to follow until they get eaten by the leopard.
Until they get chewed.
So thank you all very much. Please make your comments in your app. There's a PDF that has some of these cases, so you're welcome to cruise through that. And you can also, there's a tablet that you can write great on this for the session. You can do 5 stars, so just hit that button. But do give us some feedback, and you can type some things in about what will make this better or worse, or if you want it repeated. Thank you so much.